Welcome, Anita ma'am, for giving us this opportunity to learn from you. And I think we will start right away. I request all the participants to keep their mic in the mute, and we will take questions at the end of the session. Ma'am, let's start. Ma'am, can you hear me?
Yeah, sorry, I was mute. Hello?
Yeah, ma'am.
Yeah, am I audible now? Yeah.
Yes, ma'am, you are very well audible.
Thank you so much, Nathan. So we shall be discussing about respiratory distress in newborn with representative diseases, two main representative diseases like meconium aspiration syndrome and respiratory distress syndrome, and that is hyaline membrane diseases. And these two diseases will constitute of almost 60 to 70% of the respiratory morbidity in neonatology. So it is very important that we should know every aspect of these diseases. So like babies are not just miniature adults or not just miniature children, they are very unique. And when we talk of pediatrics, the neonates are a special population, which are especially unique in terms of the various physiological and anatomical differences. So that if you don't know the differences, it would be difficult to understand about the respiratory morbidity. So a brief, I would say this presentation would talk about the RDS in neonate, unique physiological differences, term RDS and preterm RDS, and after that key messages. So to introduce the care of a respiratory distress baby starts from the antenatal period. There is a lot of things which are supposed to be started from the antenatal period. It is just not that we should know about when the baby is there, what has to be done. So if we really need to have a good outcome of baby newborn with respiratory difficulty, we have to hit the care from the antenatal period. The in utero transfer is always best because there may be problems which can be only taken care at a center which is equipped with all the new special advanced facility of equipment like high frequency ventilation, invasive ventilation, or surfactant administration facility. Then resuscitation is the key because the two major diseases, which are hyaline membrane disease and meconium aspiration syndrome, has onset within early hours of life and even in the delivery room. So it is very relevant that resuscitation is done properly. And delivery room care has a lot of special things which has to be learned. And we all have to progress towards gentler ventilation. So a few physiological differences. We have to know about the physiology of first place. We have to understand that newborns are immature in terms of immaturity of lungs, heart, and brain. There is surfactant deficiency. There is a rapid phase of organ growth. And the two unique diseases, which are RDS and MAS, can both be complicated by persistent pulmonary hypertension of newborn. So what important part of the newborn is that they have a very small head, mandible. Their oral area is pretty small. There is a large tongue. So overall mouth opening is difficult, and in that way the access of airway can become difficult. So as you can see that newborn cricoid is newborn larynx is very pliable and it has a tendency to collapse, which more so aggravates the alveolar collapse also. And if we know these differences that their head is large, so all these things become important to take care of airway opening and maintaining of the airway. So intubation is relatively difficult when we compare it with the children. Then their airways are small, and the resistance of airway is inversely proportional to the radius. So with the smaller airway, the increase in the resistance becomes exponential even with the small, minute blockage of the airway. The other one is that their lungs columns are less. They have tendency to collapse. Their alveoli has a tendency to collapse. Their FRC is low, and the chest is compliant. So their overall lung volumes and spirometry variables are lesser. There is compliance is low because of the surfactant deficiency, which we will talk in detail. So surfactant is something which helps the alveoli to keep them distended, and without surfactant, the alveoli are collapsed. When with the surfactant, they becomes better, and the gas exchange improves. When we talk of gas exchange, we have to also understand the difference that in the newborn in first few months of life, there is a lot of fetal hemoglobin, which has very high affinity for the oxygen. So their oxygen unloading capacity is less. The oxygen dissociation curve is shifted towards the left in the newborn, and they are very prone to hyperoxia, and in that way they are increased risk of bronchopulmonary dysplasia and ROP. Then their control of respiration is also immature. Their respiratory rates are high. They are prone to apnea. They have paradoxical response to hypoxia. They have decreased response to hypercapnia. So all these things, physiological difference has a very important role in when we talk of non-invasive ventilation and triggers and invasive ventilation. Then their consumption of the oxygen is also very high. So now, when we have learned about the physiological differences, we will talking about the assessment of respiration. So how would you define that this baby is having respiratory difficulty? We really have to identify their normal rates are pretty high. So to a person, to a lay person or even adult physicians may think that this respiratory difficulty is pretty high. So we have to really understand that what is really respiratory distress in the newborn. For the assessment of respiration, we have to see what is abnormal. That is, respiratory rate more than 60 would be taken as abnormal as a tachypnea. Other manifestation would be the grunting and stridor. The grunting is an attempt to open the alveoli, and it is a particular sound which we will see will be learning in the video. Then a stridor occurs because of the upper airway obstruction, because of the tendency of the laryngeal apparatus to collapse. Then retractions, their chest walls are compliant, their alveoli are collapsible. So retractions occurs in both in form of subcostal and intercostal retractions. And intercostal retractions are per se important for the parenchymal pathology manifestation. Nasal flaring is other use and is a manifestation of use of accessory muscle. Then because of the collapsibility of alveoli, there could be decreased air entry, unequal air entry, or absent air entry. There could be adventices found in forms of crypts. These is not that much common, but it may occur in the older babies. And of course, the cyanosis, it's relevant, but cyanosis manifestation is also not very visible with the naked eye. So pulse oximetry has to be done. Then one has to also look for scaphoid abdomen, especially when we talk of in case of congenital diaphragmatic hernia. So this is a video of baby with respiratory distress. We will listen to the we will see and listen both to understand it better. So in this video, we saw that breathing was very fast. There was retraction, both intercostal and subcostal. There is a sound which is coming, which is a form of grunting. So this is how the newborn grunting is there. So these are important manifestation of the breathing difficulty in newborn. So this baby is having respiratory distress, and that too is a kind of moderate to severe category. So to quantify the magnitude of the severity of the respiratory distress, we have to have a no respiratory rate, which has been categorized in three different gradients: less than 60, 60 to 80, and more than 80. Then cyanosis, that should be absent in 0. If cyanosis is on room air, then it is 1. If it requires more than 40% of oxygen to maintain the saturation, then it is 2. Air entry can also be quantified as good, decrease or barely audible, retraction as none, minimal or marked, and grunting as none, which is audible by stethoscope and which can be audible by unaided ears. So in the previous video it was just audible by unaided ears. And a score of more than 6 is called as impending respiratory failure. This is a Downe's score chart, and which was basically given for the term infants. Another one which more so take care of the chest wall compliance and the collapsibility in forms of retraction especially. So it takes in account of upper chest retraction, lower chest retraction, and xiphoid retraction. and grunting and nasal flaring are others. So this is the diagrammatic representation to look for that what is called as upper chest retraction, what is lower chest retraction, and deferred retraction, and then to quantify. And in this score also, a score of more than 6 to signify the severe. So coming to the case first, we will discussing about the case of hyaline membrane disease. So this is a 25-year-old gravida 1 mother who had severe preeclampsia and straightened preterm labor at gestation 27 weeks with estimated fetal weight of 900 grams. So can anyone tell me, as I initially told that this is something which has to be start from the antenatal period. So what can be done to improve the outcome of this baby? Anyone can unmute and tell about the answer. What could be the option? Am I audible?
Yes, ma'am, you are. Ma'am, very less participation is there, ma'am. We can proceed with the presentation if nobody is. The MGSO has been said by Shreya.
Yes. That's correct, Dr. Shreyas. That is one of the important strategy. Apart from that, what we should take care of is antenatal steroids. So the steroids has lot of importance. It decreases the severity and incidence of respiratory distress apart from other morbidities. So it has to be given before less than 34 weeks of gestation in case of threatened preterm labor, and both dexamethasone and betamethasone are recommended. The other strategy which Dr. Shreyas has told will also be coming to that. So pregnancy was continued with this steroid, and again at 29 weeks of gestation, delivery was likely because mother has gone into the leaking. So another intervention which can be done is antenatal magnesium sulfate, and this is given as 4 gram bolus and 1 gram per hour infusion for 12 to 24 hours. So this is something which helps in neuroprotections, and we want our baby not to be improved with respiratory distress, but also to be having intact brain. So we should take care of the brain also, which is also done by steroid by reducing IVH and magnesium sulfate in terms of the lower risk of cerebral palsy in later ages. So case continued, baby is about to deliver and would be probably requiring resuscitation. So let us talk about delivery room management. So in the delivery room, especially in the preterm case, we have to have a plastic wrap that is called as wet-in bag resuscitation, which helps in thermoregulation. We have to have oxygen saturation targets. So we have to follow delivery room charts for the oxygen, and we have to use the blenders. Then TP's resuscitator, which help in maintaining the PEEP in the delivery room, because in the respiratory distress syndrome, the positive end expiratory pressure is very important. So this is plastic wrap, which and this helps in maintaining the temperature. Then these are the saturation targets for the baby who is preterm. We can start with the 30%, and then we can modulate the oxygen FiO2 concentration as per the saturation targets. Then TP's resuscitator. This is a picture of resuscitator in which a TP's resuscitator is there. It is a different from the ambu bag, that it helps in maintaining. It also provides, apart from the PIP, that is positive index respiratory pressure, which is not possible in the conventional self-inflating resuscitation bag or ambu bag. So the TP's resuscitator is an important device which can help in the delivery room stabilization of the respiratory distress, and which should be ideally practiced. The baby was resuscitated and it developed respiratory distress soon after birth. So what should we do next? So we are coming to the CPAP, and we will discuss it in a bit detail, because we are talking of the respiratory distress, and then CPAP is very important and primary management of respiratory distress. And over the last 2 decades, it has evolved a lot in terms of the understanding of the CPAP and its modulation. So CPAP helps in splinting of airways. It helps in the improving the collapsibility of lung by continuously distending the alveoli, because the RDS at HMD is the main disease where the collapsibility of the alveoli is very significant. So by virtue of providing positive index respiratory pressure, CPAP helps. It helps in decreasing, improving the positive index respiratory pressure, so gases exchange improves, and thereby pulmonary vascular resistance decreases. Then it also helps in decreasing the rates of apnea. So CPAP has very important outcome, and when we compare with other strategies like invasive ventilation or invasive ventilation with surfactant or CPAP alone, it is always, you can see with all the meta-analysis, it has always become better, and it improves and decreases the surfactant usage in 50% of the cases. So coming to the what role of surfactant. So first, if your baby is there for the respiratory distress, we have to start with the CPAP, and then if it fails, we will be discussing about those. Then we have to go for the surfactant, which is basically a combination of lipid, phospholipids and proteins. And the surfactant protein B and C are the main protein which helps in the surfactant activity for the decreasing respiratory distress. So surfactant amount for the adult would be 4 milligram per kg. For the term would be 100 milligram per kg. In preterm baby, normally it is less than 5 milligram per kg. So that's when most of the surfactant vials dose have 100 milligram per kg of surfactant for their uses. So surfactant could be natural or synthetic. Natural surfactant are animal derived and are costly. Synthetic surfactant are not much costly, but they are not at par with the natural surfactant mostly. So these are the few examples which are available in our country: the Curosov, Surfanta, and Neosurf. So the Curosov is from the porcine lung, the Surfanta is from the bovine lung, and Neosurf is from the calf, bovine calf surfactant. So when we have to consider the surfactant, when there is a persistent severe respiratory distress, and on the CPAP your PEEP is more than 8 and FiO2 is around 35 to 40%, and on that FiO2 we are not able to maintain our saturations more than 90%. The surfactant could be given early within 2 hours of birth, that is called as early rescue, or late, that is after 2 hours of birth, that is called as late rescue. When there is no antenatal steroid, previously it was used to be considered as a prophylactic, but that is gone these days. So mostly the surfactant can be given either by endotracheal tube with the side port for the surfactant, or it can be given by other less invasive technique which are becoming popular these days. So invasive, there are strategies in which we call as insure. We have to intubate the baby, give the surfactant and extubate on the CPAP. Less invasive, that is LISA or MIST or SALSA. So LISA is less invasive surfactant administration, MIST is minimally invasive surfactant administration, and SALSA is surfactant administration through LMA. And then non-invasive, that is nebulized surfactant delivery, that is also coming up recently. So in the insure, what we do, if baby is failing on the CPAP, we have to intubate to give the surfactant. Then we administer the surfactant. Then we give positive pressure for a few seconds or maybe for 15-20 minutes. And then within 1 hour, we extubate the baby to CPAP. This is called as insure strategy, and this has come a long way from the 90s, that it is no longer mandatory that if baby fails on the CPAP and you have to give surfactant and then continue on mechanical ventilation just by the convention for some time. You can extubate the baby if the baby has compliance has improved drastically. Then LISA, in the LISA, what is done? You just open the airway and do direct laryngoscopy, and then insert a oropharyngeal catheter in the larynx airway, and then give surfactant through that. So what it does, it avoids the need of extubation, need of intubation, and while baby is being continued on CPAP, on that only it can be given. Then coming to the non-invasive respiratory supports, so these are nasal CPAP, NIPPV, HHFNC, nasal high frequency ventilation, and others. So NIP, when some baby fails on the nasal CPAP, we can continue again, try to improve this baby by giving non-invasive support, and we still continue on positive pressure width. We will discuss it. So and another strategies is also heated humidified high flow nasal cannula, in which apart other than CPAP, the nasal cannula is there, and heated humidified oxygen is given, blended gas is given, and baby is maintained on the high flow. So this is also one of the strategy which is being compared head on head with nasal CPAP for primary management of RDS. So then if the baby fails on the this NIPPV or CPAP, so how would we know? Even if on the CPAP and surfactant, if the baby is having increased work of breathing, that is Downe score of more than 6, or failure of CPAP or supplemental oxygen, then we have to, or baby is having repeated apneas or shock, and blood gases are showing metabolic acidosis or respiratory acidosis with PCO2 of more than 55, we have to proceed for the mechanical ventilation. So for mechanical ventilation, if you have to start a baby with HMD on respiratory support, we can choose SIMP mode with PSV or PIP of 18 to 25 and PEEP of 6 to 8 with I time of 0.25 to 0.35 with rate of 40 to 60. Then another strategy which is important is permissive hypercapnia, and it is accept when we are when your baby of RDS has gone after 72 hours, then just to avoid the ventilation induced lung injury, we can accept the PCO2 of more than 55 on mechanical ventilation if our pH is acceptable. Then when can you extubate? So for to check the extubation readiness, we have to see that our PIP are less than 14, FiO2 are less than 35 to 40, and then overall MAP is less than 8, and rates are around 30 to 40. In case of RDS, to facilitate the respiratory morbidity, caffeine is recommended, and steroids can be given in selective cases if the invasive ventilation is becoming prolonged. To summarize, respiratory distress or HMD disease management involves antenatal steroid and magnesium sulfate. We have to be very proactive for the delivery room management. We have to give early CPAP. We have to give surfactant by less invasive surfactant strategy as much as possible. If we have to at all ventilate, we have to choose appropriate ventilation, choose for the lung protective strategy in form of permissive hypercapnia and gentle ventilation. And we have to try proactively for the weaning. And we can again wean on the non-invasive positive pressure ventilation earlier. And over and above supportive care cannot be more emphasized, because not only oxygen ventilation, but the nutrition and nutrition, asubsistent feeding play very important role. Then coming to the another case. So we will just briefly discuss about the meconium aspiration syndrome. So approximately 13% of all live births which are born through meconium strain lichen develop respiratory difficulty, and when this meconium strain amniotic fluid born baby developed respiratory difficulty, we take it as a MAS. So criteria for diagnosis would be there should be meconium staining, and there would be respiratory distress after delivery within 6 to 12 hours. Who are the at risk? Babies who are basically post-term or post-rated are at risk of meconium aspiration. In the examination, what do you find? Apart from the usual features of respiratory difficulty, that is tachypnea, retraction, cyanosis, nasal flaring, grunting, and barrel chest, we see meconium staining, and there could be lability of saturation because there is persistent pulmonary hypertension risk is higher. So these are a few pathophysiological mechanism, like they have airway of, in case of because of meconium can irritate the lungs, it can form chemical pneumonitis, it can obstruct the airway by releasing the valve mechanism obstruction, and it can secondarily deactivate the surfactant. So in the meconium aspiration syndrome, the severity can be categorized as mild, moderate, and severe. And if the baby requires less than 40% of oxygen within 48 hours of life, that is mild. If requires more than 40% of oxygen, then it is moderate. And if requires assisted ventilation, it is severe. These are just criteria, more so the subjective assessment and chronology and overall speed of progression is also very important. So when we talk of meconium, there is always a question of vigorous and non-vigorous. And most probably you all know that what is vigorous. So assessment of vigorous and non-vigorous has to be done within the delivery room. And vigorous baby is defined as those baby who have a heart rate of more than 100, having a good muscle tone and good respiratory effort. And even if one of these is not there, the baby would be non-vigorous. A typical chest X-ray of the meconium baby is like they have a hyperinflated chest, they have a diffuse lung infiltrates, they have air leaks, they could have atelectasis also. So a few important things which can be done to decrease the severity is amnio infusion, which is still not very much relevant for the Western countries, but in our setup, in a low medical income country, amnio infusion has some role by diluting the meconium. Then delivery room management, there has not been of change in the resuscitation in terms of the delivery room management of meconium. And now there is there is no need of routine intrapartum oropharyngeal suction, nor there is need of even endotracheal intubation and suctioning even in the non-vigorous baby these days. So routine intubation and tracheal suctioning is no longer suggested, and meconium baby can be continued as a normal baby for the resuscitation and intubation in delivery room. Emphasis should be made on initiating ventilation as early as possible, and use of a higher bore catheter should be used for suction because the meconium can be thick and it may not be easy to remove the thick meconium from the oral airways. So the management involves general management to ensuring normothermia, normoglycemia, normal perfusion, associated asphyxia, because in case of non-vigorous baby there would be associated asphyxia, so we have to take care of that. We have to take care of dyslipidemia. There is no role of steroids or prophylactic antibiotics. In respiratory management, we have to we can start CPAP in milder cases. Otherwise, if the CPAP fails, we have to go for mechanical ventilation. Surfactant can have role in selective cases where there is a homogeneous whiteout appearance, and air leaks can be managed by small air leaks can be managed by high frequency ventilation, and the PPHN requires pulmonary vasodilators. So a case of 40 weeks mother with meconium-assisted amniotic fluid, and pregnancy was uncomplicated. Maternal and prenatal investigation were normal. Mother went into labor with fetal evidence of fetal distress. The baby delivered is limp and is handed to you. So in the delivery room, we have to define whether the baby is non-vigorous or vigorous. So obviously the baby is limp, it is non-vigorous. Then there is no need of routine suctioning or endotracheal intubation. We have to start the positive pressure ventilation in baby who is limp as early as possible. So the consistency of meconium has no relevance when you talk of thick or thin meconium for the line of management. So this baby who is born in the MSAF is given CPAP and transported to the NICU on the CPAP. At the examination in NICU, the baby has respiratory rate of 70 with minimal retraction and grunting. Baby is started on CPAP of 5 and FiO2 of 30%. Over the time, baby's respiratory distress worsens, FiO2 requirement increases to 50%. There is increase of work of breathing in form of the worsening of hypoxia, retraction, grunting. So now we have to intubate because the FiO2 has gone to more than 50% and it is becoming severe. To maintain the oxygenation and ventilation, we need to have proceed for the mechanical ventilation because there is CPAP failure. So initial ventilation is strategy. So again, the mode of ventilation is altogether a separate topic, but most commonly SIMV or assist control mode that can be chosen. The initial setting in the meconium would be a PIP of higher towards 22 to 25, a PEEP of 5 and rate of 30, and enough expiratory time we should give because there is an increased risk of auto-PEEP. In this, even any case of respiratory morbidity, the setting should be such that it abolishes all the work of breathing of the baby, and baby should, whatever ventilation strategy you choose, whatever the setting, at the end of after the initiation of ventilation, the baby should be comfortable in the form of retraction and tachypnea. So the numbers, one should not chase just the numbers. The baby's clinical subjective breathing effort is also very important. So what if more investigation would like to perform? Obviously the blood gas. So which shows a pH of 7.33, PCO2 of 43, PO2 of 75 and bicarb of 21. This is pretty fine blood gas. So chest X-ray is done, which shows typical features of hyperinflated chest with heterogeneous infiltrate with some air pockets here. So baby is on SIMB, is agitated, has level oxygenation. So now what we suspect, because meconium aspiration syndrome is something which is very commonly associated with the PPHN. So we have to check for the preductal and postductal oxygenation. And if the SpO2 difference is more than 10%, there is a liability of saturation, and echocardiography shows suprasystemic pulmonary pressure with the RARV dilated and shunting through the vital channels, that is PDA and ductus arteriosus and foramen ovale. Then it points towards the PPHN. So echo is suggestive of PPHN, and the baby's ventilator requirement increasing. There is more need of FiO2 requirement for the correction of hypoxemia. So what needs to be done further? So this primary management of the PPHN would be like pulmonary vasodilators, and we will further see. So over next some hours, baby's blood gas is worsened, baby's pH is 7.18, CO2 is 55. So hypercapnia is there, hypoxemia is also worsened, and there is coming metabolic acidosis. Previously, PO2 was more than 70, PCO2 was 43. Now the CO2 is also worsened and PO2 is also worsened, and metabolic acidosis is also setting up. So again, the ventilatory strategy was this. Now we have to optimize the ventilation. So PIP was increased, PEEP was increased, and FiO2 was 100%. Then a probability to shift the baby to the high frequency ventilation was done, and baby was shifted to the HFO. And MAP was so when we talk of HFO, mostly when our mean airway pressure on the conventional ventilation is more than 15, we switch to the high frequency ventilation in such kind of heterogeneous disease with air pockets, and the MAP on the high frequency should be 2 to 3 centimeters above the conventional ventilation. The amplitude should be 2 times of the MAP, and frequency would be 8 to 10 in the term babies, and FiO2 as per the SpO2 targets. After high frequency ventilation, the gases has improved a bit. There is a pH of 7.41. PO2 has improved, pica is towards pretertent, but hypocapnia is there, which is just not acceptable. So we have to decrease the amplitude and increase the frequency. Then after some time, our FiO2 requirement has also gone down. MAP is also becoming lesser. So can we think of to extubate the child and extubate or wean the child to conventional ventilation? So suppose if in this case, if your PPHN is worsening, then what are the other adjuncts we can have? So we can have supportive management and pulmonary vasodilator, which can be form of supportive management, that you have to increase your systemic pressure to counter the pulmonary pressure. And alkalinization and hyperventilation are not recommended because of their potential adverse effect on the brain. If the NO is there, it is the first line treatment and the ideal treatment. Otherwise, sildenafil magnesium sulfate can be tried. So sildenafil is mostly started in 1 milligram per kg per dose 6 hourly if oral, and then there is a IV infusion dose also available. In case of meconium, there is a lot of lability, so sedation and muscle relaxation can be tried on SOS basis. Surfactant in meconium Swayson syndrome can be considered if there is a whiteout kind of appearance and chemical pneumonitis is picture is more towards more side. So in that case, if the FiO2 requirement more than 50%, it can be given. The two strategy are for the meconium can be done. So surfactant has helped in decreasing the need of ECMO in trials, and it can be given either by bolus or lavage strategy. So if it is if PPHN is not responding to our sildenafil, then we can start with the INO if our oxidation index is more than 25. So INO, again the INO practice strategies, again a lot of things are there that once you start the INO, how you have to monitor, how you have to decrease the NO dose, and then how you have to wean it off. Other therapies which are investigational are prostacyclin, bosentan, and magnesium sulfate. Last resort, if there is refractory hypoxemia, could be ECMO. So in this baby, INO was required, and after 24 to 48 hours, baby improved and was weaned off. So thank you. And at the end, I would say that in case of that both of these two diseases are very relevant. The RDS is basically long compliance disease in which your pressure, your main emphasis would be towards the opening of the alveoli and improving the surfactant depletion and CPAP and surfactant. Most of the baby would respond to the CPAP and surfactant. In MAS, we have to be very careful with the ventilation. We should judge that whether it is a homogeneous kind of disease or heterogeneous kind of disease, and air leak and PPHN is very common. So we have to take care of the supportive management also. So thank you.
Thank you, ma'am, for incredible presentation yet again. And I found that although participation was less, but they were participating. And uh, I think, ma'am, I have not received